What do you do with a pain patient who has more pain after wearing a B-splint? Jeff, I'll let you read again.
Yes, sir. Um, okay, a couple questions about this one. What do you do with a pain patient who has more pain after? Well, the first thing is take it out. Okay, I mean, I'm just, I know you knew that already, Steve. I knew that. But the point is, what the pain got worse. Okay, well, I don't know exactly what pain that the person was having to start with. Was it joint pain or was it muscle pain?
Right.
So we don't know. But if it was, we presume it was muscle pain, I guess. If you're wearing a B-splint, typically that's an anterior deprogrammer. That's really designed to help with muscle incoordination, that kind of pain, and clenching. Of course, we can't get rid of clenching 100%. We just decrease the amount of muscle contracted force by 70% by putting an anterior deprogrammer in. So you say, well, it's not going to go to zero maybe, but a person that has a lot of headaches and a lot of pain like that from clenching will get a lot better by wearing a B-splint. So if it gets worse, it makes me think it's not a muscle problem. It could very well be a joint problem. Okay, so if it's a joint problem, a B-splint or any kind of anterior deprogrammer is likely to make it worse. Whereas the theory on that is that causes an increase in the seating of the joint and whatever intracapsular disorder is going on, it's just pressing on perhaps retrodiscal tissue, or there's a lot of effusion in the joint or inflammation. So that could be a reason. The other reason would be it's possible that the B-splint is not adjusted correctly. It could be that if you've made a full coverage lower, like a BioStar blank, and made your own deprogrammer on it, or if you had a lab make it, and you're still getting posterior contact. When they touch maybe in the front, there's no posterior contact. But if they have a deeper curvus spi, their posterior teeth can't interfere as they protrude out onto that little ramp, and they're bumping into the back, and now they find that spot and they work on it and they crank on it, and they're going to increase their muscle activity, not decrease it. Or if they're going laterally, they pick up a cuspid. We always adjust them so that if they slide forward, back, they never fall off the ramp. If they go left and right in any direction, they cannot catch the cuspid on either side. Sometimes you have to carve away the lateral side of the ramp to make sure the cuspid has a free path. If they can find a cuspid for some reason, they'll move their jaw all the way over there and camp out on it and just crush that cuspid and work on it. Then you get more pain. So that's another possibility why it could be worse.
Yeah. And just reiterating, I think that when pain is mentioned, is it joint, is it muscle? And Jeff's done a great job of explaining adjustments and stuff like that. I have had some patients that when we place an anterior deprogrammer, whether it be a B-splint or some sort of Lucia jig or something of that nature, that I give the patient instructions on trying to relax their muscles and relax their jaw instead of trying to hold their jaw out forward and trying to hold it in. I've had people that are big clenchers, and as soon as you put that in, they're in there just trying to hold it in, whereas you're actually trying to relax that. So I get them to open and close several times, move their jaw forward and back over the splint or over the anterior deprogrammer some, and trying to get them to actually relax their muscles instead of trying to hold it in. That'd be the only other thing that I'd add to that.
One other thought I was just thinking in relation to what you said, if they are moving forward and they're sliding all around trying to hold it in, but if they're moving their jaw in a protrusive way and they do have a deeper curvus spi, it's kind of like, well, what do you do? If you start adjusting on that back molar, you're almost perforating it. It's totally fine to just cut off the back molar. All that base does is helps hold it stable. So it's not, the patients are not afraid that it's going to fall out or they're going to swallow it. Of course, they all say that, but they want it to be secure. I think that's more comfortable for them anyway. But it's totally fine to just cut off the second molar completely and round it and smooth it. Your retention will still be good, and that also gives you enough room maybe in the back for a deep curvus spi.
Any instructions, Jeff, if you do cut off the second molar as far as length of wear? Is there any limitations then if you're not full coverage with the splint?
Oh, you're concerned about super eruption?
Yes, yeah.
Okay. So here's the answer to that. Not a problem. The reason it's not a problem is because they're not wearing this 24 hours a day.
Okay.
They wear it at night only. They're wearing during the daytime. We just tell them as best they can, lips together, teeth apart, but they got to eat, and they can't typically do their job with that B-splint in place. So we use it primarily as a nighttime only appliance, and therefore even the little bit of contact during the day in chewing and swallowing, little tiny light contact is enough to keep the posterior teeth from super erupting. So it's not a problem to cut off the back end, as long as they're not wearing it 24/7.